Good to hear from you.
Hi, Happy New Year.
Happy New Year.
Okay, recording is on.
Okay, dokes. Thank you very much, everybody, for joining us for this first session. I know the last two sessions were recorded, so if you have any queries about those two sessions, please don't hesitate to send us your queries and we will promptly reply, yeah? So we're going to talk today about pressure injuries. And unfortunately, we've been talking for pressure injuries for so many years. The first documented pressure injuries were from Egyptian mummies, which is about 5,000 years ago. But it's still a huge impact on our patients. We are still seeing patients suffering emotionally, physically, as well as impacting not just the quality of life of the patients, which is very important, but also, unfortunately, impacting our work, impacting our healthcare system.
I'm Sally. I've been injured since January 2020 when I decided to crash my motorcycle into a central reservation. It left me with T10 incomplete spinal cord injury and some other horrific injuries that left me fighting for my life. My first pressure sore was in April 2021, and that was just after I returned home from the rehab centre. That was about 2 months to recover from, so that was bed rest because it was on the bottom of my foot. And the longest one I've had was 5 months in bed rest with one about the size of the palm of my hand on my bottom. And that was from 50 minutes on the physio's couch, having worked onto my legs. In rehab, they said how important it was to not get a pressure sore. They didn't actually say why it was important you didn't get a pressure sore. It's important not to get one in the first place because they are so hard to treat. They cost so much money to the NHS and to you financially because I can't work, I'm on bed rest, I can't earn. I've lost all my earning capacity. Power to be promoted, that's all gone because I'm in bed recovering. What they do tell you in rehab is to look out for red spongy marks. If you see anything, keep off it, keep the pressure off until that redness goes. So I do skin checks every morning when I get up, every evening when I go to bed, and every time I go to the bathroom, I check the vulnerable areas. It's hard. It's hard. So for me, I miss those red spongy signs, or they don't happen. For me, it is a fluid-filled blister that comes up, and by which time the damage is already done. I was rushed to hospital with pressure sore number 22 that got infected, and the infection went down to the bone. And being in the general hospital as a spinal cord patient is a scary place. They don't do spinal cord injuries in the regular hospital. They didn't know how to handle me. And following that, it prompted me to make sure that I had an emergency bag packed and an emergency care plan put in place, which is now attached to my medical records at the GP surgery. My daughter's got a copy, my mum's got a copy, and there's also a copy in my overnight hospital bag. Damien's been a great support in getting this care plan put in place. He was really easy to talk to. He was full of great ideas and things to include into the plan that I hadn't thought about. And it was quick, really quick. It was painless and it was free of charge. Why everyone hasn't got one, I don't know. I think the key with pressure ulcers, I think it's education. Do your research. There's so much information online. And if you can prevent one from happening in the first place, that's golden. Because to treat them is just an ongoing nightmare. It just absorbs every part of your life, financially, emotionally, socially. But there needs to be a better treatment for them. There needs to be a quicker treatment, or there needs to be better prevention. better education? I'm not sure what the answer is. Welcome to Stop the Pressure Day. If you can't avoid getting a pressure sore in the first place, then make sure you've got an emergency care plan put in place. Don't end up in an emergency room like I did, not knowing what's going on, but worse still, the nurses not knowing how to look after you. Please, I implore, get one put in place.
I think it's a very emotional video. It brings us to the reality that pressure injuries don't only occur in 80-plus-year-old patients. This person is still young, as she has suffered from a spinal cord injury, and her greatest complaint is not that she's stuck in a wheelchair, but the amount of pressure injuries. She mentioned after 22 injuries, she had to go to hospital as well. She got a pressure injury after a 50-minute session with a physiotherapist. Tells us how incredibly easy it is for these patients to get them. She was told how to look out for them, but she was never told how to prevent them. She then talked about a care plan, which is so easy to implement. Do we have anything like that in place to teach our patients? Education is key for our patients and their carers, because their carers don't know how to manage. Some nurses, as she said, don't know how to manage pressure injury prevention as well. So a lot of takeaway messages from these. It's costly as well. If you look at the amount of money, we don't need to go through the whole issues, but remember that most of these pressure injuries are preventable with just a little more care. More importantly, with education and awareness of not just the patients and their carers, but also education of the healthcare professionals. Quick question here. Let's start this off. Have you ever had a pressure injury yourselves? Okay, we'll give it a few more seconds. Okay. So most of you said no, you never had a pressure injury yourself. Let me remind you, the last time you bought a pair of new shoes and you ended up with the blister at the back of the shoe, that's a pressure injury. What is important there to understand is that anybody can get a pressure injury. Wherever there is mechanical loading, there can be a pressure injury. We've seen the video of that girl who's, apart from her spinal cord injury, is a very healthy person. She still gets a lot of pressure injuries. But what is very, very important here to remember is tissue tolerance. Who can get a pressure injury is everybody, but who is more prone is more important to remember. So how much pressure do you think is needed to occlude circulation? 17, 70, or 170 millimeters of mercury? Remember those old sphygmomanometers? Just one puff takes it up to 30. So 17 is really little, 70 mid-range, 170 quite high. Jonathan? Can we share the poll, Jonathan, please? Thank you. Few more seconds. Okay, we can stop it there. So most of you said 70. Actually, it is really low. 70 millimeters of mercury is enough to occlude the capillaries. So even the slightest, tiniest pressure will occlude the circulation. This is very important to remember because you don't need a lot of pressure. Anything can cause a pressure injury. So when there is pressure, we used to talk always about bony prominences, but that we will see that that has changed. But pressure points are still very, very important for us because it's easier to get a pressure injury in bony prominences. Basically, the pressure will pinch the capillaries, not allowing that circulation to go. When you have a sliding patient, you will have shear, and that shearing is even worse because now you have angulated the capillaries as well, apart from the pressure. So we have this development cycle where you have that shearing, the pressure, the blood supply is cut off, no oxygen going there, and therefore will lead us to that occlusion of blood. However, when there is pressure in an extended period of time accompanied by shear, temperature is higher as well, then or lower, then we will have it accelerated. So remember the tissue tolerance. So you've got older patients, you've got patients who are very sick. These are the patients that will get the pressure injuries quite easily. And we'll look at this when we are talking about the risk assessment that we can do, and I'm sure that you do for your patients. So where do we get the idea of turning the patients? If you remember, when the patient was talking, she said she got one after even just 50 minutes. That was probably a stage 1 pressure injury, because if you have pressure which is about 30 minutes, that will give you a stage 1 pressure injury. If you leave that for up to 6 hours, it can take even up to 36 hours to relieve, and anything above 6 hours will give you tissue necrosis. So basically what we're saying here, if you don't turn the patient at least once during a shift, you are kind of guaranteed that the patient will get a pressure injury. So look at making a holistic assessment of the patient. We will look later at the risk assessment scores, but getting that general assessment of the patients is really, really important, because it is not just the things that we have in the Braden or the Norton or the Waterloo, but also looking at the general health of the patient. How much are they prone to get these pressure injuries? Which leads us to a very important question. Things like moisture, malnutrition, can these cause pressure injuries? Okay, we'll give you just 5 more seconds. Please participate more in the polls. Remember, there's no good or wrong answer. It's just participation. Okay. So most of you said that it is true. It's kind of correct, but it is not entirely correct, because the direct cause of a pressure injury is pressure and or shear. So that localized damage to the skin or soft tissue, usually over a bony prominence. And the inclusion of this word usually is quite recent, because previously we used to look only on bony prominences. Now we're looking at device-related pressure injuries as well. The other thing that has changed is we're referring to them as pressure injuries, not pressure ulcers anymore. This is because of this statement here, where we are seeing that a stage 1 is not an open ulcer, so we cannot call it a pressure ulcer. So generally, pressure injury refers to all the stages. So that combination of pressure or shear will give you the pressure injury. The other things like microclimate, nutrition, perfusion, etc., these make this tolerance of the skin less. So although they are not a direct cause of pressure injuries, however, they precipitate to pressure injuries by reducing that skin tolerance. And remember, when we are doing that skin inspection, which should be done at least once every shift change, usually we just look at these pressure points, which we are used to, but you know that now is not entirely correct. We need to look all over the patient's body, skin assessment, which is head to toe. So, talking about how much are avoidable or unavoidable, and this discussion has been going on for years and years, and I'm sure that you recognize that lady there on the left-hand side, Florence Nightingale. She was saying that basically pressure injuries are usually the fault of the carer, not the fault of the condition of the patient. And she already was talking to families about changing the position of the patients. They didn't know exactly the anatomy and physiology behind it, but they did realize that this would help. So basically, we are saying that many times nurses are blamed if a pressure injury occurs. The most important thing to remember is that pressure injuries are mostly avoidable, and there has been discussions. Jean-Martin Charcot will talk about him during the diabetic foot ulcer, but he was already thinking that immobility of the patient is directly linked. He thought it's because of the disease, but now obviously we know it's not because of the disease. And even later on with another physician, they were thinking about removing compression, keeping the patients clean. So we've known these things for hundreds of years. However, more importantly is to understand that now we know that the most important things is our commitment, our knowledge, and accountability. We think about malnutrition, we think about turning the patients, etc. But more importantly is to understand that we have to make sure that everybody that comes in contact with these individuals has enough knowledge to be able to take care of these patients. So basically, how can we understand if the pressure injury was avoidable or not? So basically what we need to do is make sure that we evaluate the condition of the patient, skin condition, tissue tolerance, etc. Make sure that we implement the care plan, which is individualized to that patient. We monitor and evaluate the impact of the care that we are giving and revise accordingly. If we've done all this and we can document and show that we've done all this and the pressure injury still occurs, then this is considered as unavoidable. There could be many things. For example, the medical condition of the patient, we cannot turn the patient, or else the patient or the relatives doesn't give us consent after we have extensively giving them all the information which is necessary. So can we be complacent? Can we say, you know, some pressure injuries are not avoidable, we cannot avoid them all? The answer to that is no. We have to make sure that we implement care as a multidisciplinary team. We need to involve the physiotherapists, we need to involve the nutritionists, the physicians. We work all as a team to make sure that pressure injuries are avoided as much as possible. Later in the history of medical and health provision, we started talking about quality indicators, nursing quality, and this has become very, very important because not just because of the safety of the patients, but also because of reimbursements. Hospitals, if they have a lot of incidences, not just of pressure injuries, but pressure injuries is one of them, they can also lose their reimbursement, they can lose their support, they can eventually lose their licenses. Remember about the international patient safety goals, pressure injury prevention is one very important indicator of that. And I think I've heard somebody say that in Singapore, you have to publish your number of pressure injuries, and these need to be made public as well. But we don't measure because it's a KPI. We don't measure because of all the issues that we talked about. We measure because we need to make sure that the care that we are providing is of the best possible. And this is why we need to look at doing these type of assessments, the prevalence tests, every quarter, for example, or twice a year at least, to make sure that we're looking at how many pressure injuries we have, making sure that we are not just assessing the number of pressure injuries, but also looking at the care that is being given to understand what is happening. Are our statistics changing to the better or to the worst? If there is a change, what is related to that change? What has happened in the past few months that has made these incidences better or worse? And this is why it's very, very important that we work with the quality department, the nursing quality departments, to understand what we are going to do and what needs to be done. So there are different ways how to calculate numbers of pressure injuries. So do you think this is true? Prevalence measures the number of individuals who have developed pressure injuries during a specific period. Is that true or false? Seems that you are scared of responding to polls. Come on, guys. I'll give you a few more seconds. So basically, what we are looking at, prevalence, yes, is the amount of individuals in the hospital at a certain point in time, how many have pressure injuries. So we advise a date, we go out on the units, we check all eligible patients, and once we have seen all the patients, we do a simple mathematical equation that you have at the bottom, which will give us a percentage of how many on a particular date, how many individuals had pressure injuries. Remember, we don't count the number of injuries, but we count the number of individuals. Usually, stage 1 pressure injuries are not included in the statistic, and we also omit patients who are actively dying because these are usually some type of unavoidable injuries or other types of injuries. However, also importantly, we look at the incidence measures. So an incidence reporting, which I am sure you are aware of, is reported at the time of the injury. So while the prevalence is calculating both the hospital-acquired pressure injuries and the community pressure injuries, with incidents, these are reporting just the injuries that occur during our care. So although we have the numbers at the end of the quarter with the prevalence, incident reporting should be looked into immediately. So when we are looking at incident reporting, the most important thing again is not just the statistics. What we are looking at is the determination of why and what happened. Understanding that we need to analyze everything. And the way how to do that is, this is just an example for you, which is called the fishbone analysis, where we look into all the issues that could have contributed. And there is a systematic way, obviously, how to do it. The quality department will be knowledgeable about these issues. What is important is understanding what has happened, understanding how it can be prevented at a later stage to make sure that our patients are being provided with safe care. So once we establish that we're going to have a statistical analysis, one of the important things is staging, because we have to make sure that we are staging these pressure injuries correctly, but not just for statistics. When we are staging pressure injuries, this will also determine the wound care that we need to give to our patients. So before we start doing the staging, obviously we'll need to make an actual assessment of the wound, making sure that we look at the patient from head to toe to make sure that we are looking at the whole body where there might be pressure injuries. Before you stage any ulcers, you have to clean them first, because you can remove the surfactant necrotic tissue or the surfactant slough to make sure that we are looking at the deepest anatomical location. And remember, when we are looking at the depth, we are not looking at the depth in centimeters to stage. We are looking at the depth, which refers to the layers of the skin.
Assessment and Staging of a Pressure Injury by Susan Hamilton.
I am showing you now a picture of a stage 1 pressure injury. That is when the skin is red and it will not blanch. If you put your finger on it, it will not turn white and become red again. It will stay red. The skin is not broken. Next is a stage 2 pressure injury. The skin is broken in a stage 2 pressure injury, and there is usually, as seen in this picture, granulation tissue in the middle. It may have a bit of debris inside of it, but as you can see in this one, there are nicely marked edges and a nice pink granulation bed. There is no bone showing, there is no fascia showing, and it is just down to the epidermal level. Stage 3 pressure injuries go down deeper into the fascia. As you can see in the wound, there is some fascia showing. There is a mixed wound bed here, and there is some granulation, but there is definitely a deeper wound here. Stage 4 pressure injuries, by definition, go down to the bone. That is a piece of exposed bone on this particular patient. You can see that some of the wound bed is pink and granulating, but as long as there is bone showing, then it would be a stage 4. And when you stage a pressure injury, it is always that stage. So even if it's in a healing stage, as this one is, this will always be considered a stage 4 pressure injury. It would be a healing stage 4 pressure injury. The next one is considered a deep tissue injury. The patient has an area of poor perfusion that looks almost like a bruise, but may be a deep purple marbled color over a bony prominence. That could potentially open up and become a stage 3 or 4 pressure injury. But for right now, you can't assess that because it's just in its evolving stage. So we classify that as a deep tissue injury. The other one that you cannot decide what it is now would be an unstageable pressure injury. If you look at this patient, there is a heavy black eschar over it. And as long as that eschar is there, we don't really know what lies beneath it.
So we will go through all the different stages of pressure injuries, just as a reminder to make sure that we understand well the different stages. So a stage 1 pressure injury is a non-blanchable erythema. So in paler skin patients, it appears as a patch of redness, can be a different color in darkly pigmented skin. So basically, when you press on the skin and you remove, the skin remains red, it doesn't get paler. A stage 2 pressure injury is a partial thickness skin loss, so you have just exposed dermis here, so very shallow injuries, but can also be presented as a blister with clear fluid. It's very important to make sure that when we are looking at stage 2 pressure injuries, we make sure that they are not other types of injuries like IADs or the skin tears, which are unfortunately very commonly confused. So, question here for you guys. A stage 3 pressure injury, can we see fascia, muscle, tendon, ligament, cartilage, or bone? Okay, we'll give you a few more seconds. Okay, so the answer to that is false. So when we have a stage 3 pressure injury, is a full thickness skin loss. So we can see the adipose tissue, but we cannot see fascia, muscle, tendon, etc., etc. In the wound, there can be slough and eschar, but we need to see the deepest anatomical location. And it's very important that if we are going to stage, as we said before, that we clean these pressure injuries first. The visible tendon, muscle, etc., will determine that that is a stage 4 pressure injury, which is full thickness skin and tissue loss. So again, we have all the same attributes of a stage 3 pressure injuries, but determining the thing that changes from a 3 to a 4 is if we can see the fascia, muscle, etc., etc. Well, I would like to take you to the picture at the top there, where you see a pressure injury on the bridge of a nose of a patient. Although that is not very deep in centimeters, we can see the cartilage at the bottom of that wound, so that will determine that that is a stage 4 pressure injury. An unstageable pressure injury is a stage 3 or a stage 4. However, we cannot determine if it's a 3 or a 4 because we cannot see if bone, ligament, etc. is involved. Basically, these are 3s and 4s only because a stage 2 pressure injury will not be able to have a covering of slough or necrotic tissue. How much slough or necrosis do we need to have for it to be an unstageable? It doesn't need to be covered totally. Obviously, if it's covered totally, it would be an unstageable. But if you look at the top picture, there is the slough at the top. We cannot see if there is bone visible there. So basically, what we have here is an unstageable pressure injury. If you then debride that wound, obviously we can then determine if it's a stage 3 or a stage 4. The deep tissue pressure injuries are bruises. These are hematomas, so we have bleeding from the damaged tissue underneath. If the damage is not still very extensive, if we offload these areas, there can be resolution of these injury. However, if there is continuous pressure, it will become a deep wound very quickly. Apart from the bruising that you can see at the top, we can have blisters as well, like we had in a stage 2. However, the fluid here, instead of being clear, it would be dark maroon in color because it has blood as well. Another question for you, are mucosal pressure injuries stageable or not? Give me just a few more seconds. So in order to answer this question, remember what we said previously is that in order to stage pressure injuries, we look at the layers of the skin. Now, because the mucosal membrane doesn't have layers like the skin, we cannot stage it. So basically, mucosal pressure injuries, which is usually associated with medical devices like ET tubes, is not staged. We just document that it is present. When we're looking at device-related pressure injuries, this has changed as well. Previously, we used to say medical device-related PIs. However, we know now, and we do understand that anything, not just a medical device, can cause a pressure injuries. I was reading a newspaper article about a couple of years ago where it was really, really interesting that when they saw what causes the most pressure injuries, device pressure injuries in patients in old age care, it was charging cables for phones. Patients charge their phone, they leave it on the bed, and they rest on the cable and it will produce this. However, many device-related pressure injuries occur because of lack of knowledge or awareness. Because if we know about these injuries, these are definitely preventable if we take good care of these sites. The device-related pressure injuries occur a lot of times on the head, the face, the neck, and the ears, but they can happen anywhere along the body. This is a good mnemonic that was brought about from the Canadian Association. It was published on the American Journal, where we look at the mnemonic of the device. So determine that all devices, not just medical devices, can cause pressure injuries. Evaluate all the devices. Make sure that they are safe for the patients. Verify that there is enough education how to secure these devices. Identify all the patients which are vulnerable, consider all the patients that require this, can these devices be repositioned, and obviously, very importantly, education of all the healthcare professionals. The same people came up with another mnemonic, which is the potential source. So as you see from this list, it can be anything and everything. If you remember when we were still in our schools learning the basics of nursing, we used to be told that the sheets needs to be taut, there should not be any creases. Even a crease in the bed linen can give a pressure injury. Well, these are some examples for you. I'm sure that you have come across this, but also remember that many times, some of the pressure injuries are not documented. For example, if you see that those retention sutures, we would think that that is caused because of the surgery. It was basically caused because the sutures were so tight that the circulation was occluded. So make sure that we are looking at every aspect, making a head-to-toe skin assessment for our patients. So basically, when you are doing the management of these devices, make sure that we are using high-grade devices that can be put in place safely for the patient. Make sure that they are anchored correctly. Make sure that they are of the correct size, etc., etc. One thing that we sometimes overlook is how much at risk patients are when they are going to the operating room. Most of these patients are already compromised because of their general condition. So it is very important to do a pre-op assessment of these patients, and then making sure that when we are taking care of these patients peri-op and post-op, we also make sure that we are looking at prevention of pressure injuries. So do a thorough skin assessment when the patient is leaving. Remember that the patient might have a stage 1 pressure injury because of the long time on the table or even in the recovery room. So it is very important, first of all, to document it that the pressure injury did not occur in your unit, but most importantly is to understand that we have to offload that pressure. There is, like the Braden scale, etc., etc., there is a risk assessment for the OR, which is called a Monroe. So it looks at the pre-op categories, peri-op categories, and also the post-op categories. So the scoring is very similar like the Braden. We look at the scoring to show us how much at risk these patients are, and obviously it's not just documenting the risk of the patient, but implementing as much as possible the prevention care that we can do. So make sure that we are using equipment which is proper. We make sure that we do the PPM for all this equipment, and making sure that we are positioning the patients properly. The pre-op assessment is the same pre-op assessment we look at for all the other conditions, but obviously telling us how much at risk our patients are. Then making sure also in the OR that we are using anything which is possible. There are a lot of different types of overlays that we can use on the table, which are specific for operating tables. Obviously, there are oils that can be used to enhance the TCPO2 of the skin, making sure that our patients are safe. One of the very important things is to make sure that we always keep the heel of the patient elevated. So this leads us to the conclusion of the first part. If there are any questions, you can ask them now. If you don't have any questions, we can have a quick 5-minute break, and then we'll continue with the rest of the slide. So are there any questions? Seems not. So, oops, sorry. So yeah, we can stop for a 5-minute break. We'll see you again in 5 minutes. Thank you. For joining us again. So one of the interesting things when we are talking about pressure injuries is something that some people are not aware of, which is called the Kennedy terminal injuries. And it is not something which is very, very recent. Again, talking about Jean-Martin Charcot, who is considered as the father of neurology, who was a great neurologist back in France in the 1800s. He was already thinking and describing that he's looking at acute and chronic. We consider them as acute and chronic, but basically we know that this is not the exact terminology. We have a question here. We know there is no need to restage once it's fully healed, but how we classify the VI? Okay, we will go to that later on. If I don't answer that to you, Vivian, please let us know, and I will answer at the end. Thank you. So we started looking at these Kennedy terminal injuries, and they called Kennedy because the person that published about it in the 80s was called Kennedy, so it's named after this person. And they made a retrospective study looking at these patients in palliative care units who developed a rapidly increasing pressure injury but died very close hours or days to the injuries when they occurred. So in their report, they saw two different types. The first one was a bilateral KTI, looks like a butterfly or whatever you want to call it. These appear very suddenly, so the patient doesn't have anything, then all of a sudden has this type of injury on their skin, usually over the sacrum or coccyx. And this is usually a couple of weeks, a few days before the patient expires. The second type is the unilateral KTI, sometimes referred to as the 330 syndrome, because the patient doesn't have anything in the morning, and then by the afternoon they have this problem. As you see, the patient also has a device-related pressure injury at the bottom, but we're looking at the top one. These appear, as we said, very, very suddenly, and within 24 hours, these patients expire. The question is, are Kennedy terminal injury pressure injuries, or are they something different? So most of you are replying that they are not pressure injuries, and that is correct according to the latest development. So if we look at the cause of pressure injuries, we said it was because of unrelieved pressure, which results in local ischemia. The Kennedy terminal injuries occur because, like any other organ, at the end of life, the skin starts to deteriorate. Like all the other organs, there is hypoperfusion, and that is why these changes in the skin are visible. So the hypothesis here was that KTIs are not pressure injuries. They are something different. These are unavoidable injuries, and one of the persons that started really tackling this was Cathy Trombley, who did a few publications about this. And now we are looking at, apart from the KTI, we are looking at the Trombley-Brennan TIs as well. So what they found out is that these kind of skin injuries don't only appear on the sacral area or the coccyx area, but they can appear everywhere. They found that these can be all over. They did again another retrospective study which showed that these are not pressure injuries. These are something totally different. So it's very important. And if you remember, when we talked about the prevalence assessment of our statistics, we do not include actively dying patients, and this is one of the reasons why. So it's very important as well to make sure that we are aware of these. We are documenting them properly. The KTIs appear in the coccyx and sacral area. The Trombley-Brennan can appear anywhere else. They are quite similar, but usually the Trombley-Brennans are more maroonish. But this is very important to make sure we don't confuse them with the deep tissue injury. So look at the condition of the patient, look at the causative factors, and this will give you a determination of what is happening and how to document and how to care the patient. A very interesting publication that came out from the Wounds UK, but was also documented by Kevin Wu from Canada, is looking at the risk scale of patients who are palliative care, who are in a very poor condition. We don't need to go through all of this, but it's very important for you guys to be aware of this, because we do look after patients who are very sick and at life's end. So this scale mnemonic is very helpful for you. As we said previously, it's very important to determine, and one of the things that confuses us sometimes is it a pressure injury, is it a skin tear, or is it a moisture-associated dermatitis? So first of all, look at what has caused. So the pressure injury is caused by pressure and/or shear. Skin trauma is trauma of friction, while moisture-associated dermatitis happens without friction or pressure. The one very important thing to remember is that the MASDs occur usually in skin folds, where pressure injuries do not occur in skin folds. So let's have a quick look at IADs and try to remember what IAD is, because it's very important to know one and the other so we don't confuse them. So there's a lot of definitions, there's a lot of different types of dermatitis, but obviously today we're going to look at IADs, which is exposure of irritants to the skin, where we have most commonly is feces and urine, but it can also be other effluents and even perspiration in patients who perspire a lot or have high temperatures. Quick question for you. Can moisture-associated damage present like a deep wound, for example, like a stage 3 pressure injury? Okay, just a few more seconds. Okay, so the answer to that is no, because IADs starts off just as simple maceration. When it starts getting worse, we have erosion of the skin that doesn't go deep down to the adipose tissue. So the answer to that is no. There are many different terms, but obviously the correct term is IAD. Initially, it appears that as erythema, it's very important that you remember that stage 1 pressure injury, if you press it, it doesn't blanch. However, the IAD does blanch, and it looks totally different, and obviously with the history of incontinence or other moisture in the wound and the skin. The skin can feel warm, it can have vesicles. What is very important is to remember all of these, because one of the things that is confusing is that sometimes we refer these patients to the tissue viability nurse. Remember that IAD is a dermatitis, so this branch does not go to the tissue viability. This branch goes to the dermatologist, because the dermatologists are obviously more expert here. These are the most common area of the IADs. It's all around the perineal areas. And also very importantly, like we talked with the pressure injuries, skin assessment is extremely important. There are different types of tools that are out there which can help us to document properly these IADs. So what are the stages? We have the early IAD, where the skin is still intact, there's no blisters, very regular borders, there's warmer temperature, and patient will complain of burning, stinging, or other pain. You might have seen, unfortunately, a few of these with little kids who use diapers. The moderate is bright or angry red, and you can even have little small areas of skin loss, and these are extremely painful. Remember, this is a very shallow injury, so all the nerve endings are intact, and the pain is quite bad here. The severe IAD is where now we have partial thickness skin loss. There can be oozing and bleeding. The skin layers are stripped, and you have also now adherence to any surface. So if the patient is on sheets, the sheets will stick to these wounds. There can also be a fungal rash, and this is very important to note. So the dermatologists need to be contacted immediately to give the antifungal treatment, which is necessary, because unfortunately these can worsen very, very quickly. So there are other types of categorization. However, this is just an FYI. It's important that everybody documents the same. Very importantly, that we do use these barrier creams, barrier ointments, and making sure that we clean off the patients as quickly as possible. And if there is any risk of the patient or there is any damage, to refer immediately to the dermatology department. So if you want to differentiate, if you don't remember all of this, the most important thing is the first one. While a pressure injury is non-blanchable, An IAD is blanchable, and the location is also different. The location is pressure injuries is where you have pressure and/or shear, while an IAD is usually between skin folds and areas which are exposed to incontinence or any other type of effluent, like even if you have a wound which is oozing quite a bit. One of the things that we also encounter, which is totally incorrect, is the type of documentation when the wound is healing. For example, we see a stage 4, which is documented as healing, but now has become a stage 3. This is impossible because when the wound starts to heal, the wound starts filling up with granulating tissue. Granulating tissue is made up of collagen. It is not made up of the layers of the skin. So very importantly, if a stage 4 is healing, we document it as a healing stage 4, even after it is totally healed. One thing that can help you document pressure injuries very well is what is referred to as the push tool, which is the pressure ulcer healing chart, which has been given to us by the MPUAP. You can download it for free. And it's very important, again, to make sure that everybody is aware there is enough knowledge that reverse staging is incorrect. If a stage 3 is the worst part of the wound, we documented it as a stage 3 even till the end. We stop documenting it as a stage 3 or a 4 if there is a surgical intervention and the flap is applied, because now it is a surgical wound. So we move on to a very important part, which is assessment tools. And assessment tools are extremely important. Remember when we talked about the tissue tolerance of our patients, and it is very important to identify a patient at risk. Again, we do these assessments, not part of a KPI, not to make sure that we are documenting, but we do these assessments to make sure that we implement a plan of care according to the risk. So this facilitates us to do clinical decision making, but it is not on its own. You have your experience, you have your nursing knowledge, so we combine the risk factor assessment with your knowledge to create a proper nursing care plan for our patients. There are a lot of these types of risk tools. What is very important is that we give education to everybody that is using it and making sure that we are using a comprehensive approach, as we said previously, using your clinical judgment as well. The most commonly probably used assessment tool is the Braden scale, which was developed by Barbara Braden and her colleagues to give us 6 elements that we need to look at. We score each of these, and when we get the score, the lower the score, the greater the risk of the patient there is. So according to best practice, the initial risk assessment should be done for every single patient within 2 hours of admission. The reassessment is done once a shift or if the condition of the patient changes. So, for example, we have an ambulatory patient who is not at risk at all, although then he goes to the operating theater and comes back. Obviously, the score will change. When it comes to old age care, there are different types of policies, but usually the assessment is done once a month because these patients are quite stable. However, if the condition of the patient changes, like in the acute system, we do the reassessment and implement the plan of care accordingly. Another quick question for you: can we use the Braden scale in pediatric patients? The answer to that is basically no. The normal braiding is used for patients who are 8 and above. So yes, it does include some pediatric patients, but what is very important that if you take care of patients who are under 8 years, we have the braiding queue and the neonatal infant braiding queue, which have added categories because the patients are different. And the most important thing is that, again, education and awareness is given for this. So when we are implementing the risk assessment tools, we implement the proper risk assessment tool. If you look at the risks for the braiding queue and neonatal infant braiding queue, the patients are at risk or not at risk, while with the braiding, we have the different categories. Again, the important thing is to make sure that we are aware of these types of tools, making sure that everybody knows how to document them properly. I'm not going to teach you how to do the braiding scale. I know that you know how to do it very, very well. What is very important is, again, that we score these properly. If we have a score which we are in doubt, should we give it a 1 or a 2? Give it the 1. Always choose the lower score. So again, we're not going to go all through these, but it's what is really, really important is remember that each and every single risk category has a different nursing care plan. So this is the care plan for the patients at risk. Then if you have patients at moderate risk, we have even more interventions to do. And when we have patients at high risk and very high risk, obviously, there's a lot more interventions to do. These should be documented in your policies, making sure that we are implementing the correct care for our patients. As we said, it's not only the braiding scale, there's loads of these around. However, the most common ones that we use are either the braiding or the Waterloo scale that you have here, or you might have heard also of the Norton Pressure Risk Assessment Scale. There was a comparative study between all three, which determined that all three are very good. However, it was determined that the braiding scale is more, can give us better results when the conditions of the patients are changing. Again, if it comes to risk assessment for infants and children, there are specific ones. So we can use the braiding queue or the braiding queue infant, but there are other ones like, for example, the Glenmorgan. It's up to the facility to decide which one to use. One of the unfortunate things when I go around giving these type of education to nurses is the realization of how many nurses are there who do not know how to position the patient properly. So if we have a patient who has basically a pressure injury on the trochanter area, that is a never event, that is a total bell malpractice, because we should never put the patients on a 90-degree turn. If maybe in a case it is medically indicated to do so, but usually we don't. So there is a position that we turn the patient only 30 degrees. As you see at the picture up here, when we turn the patient 30 degrees, only one side of the patient is touching the mattress. Then when we turn them, we relieve that area. The other thing is not just the 30-degree turn, but the 30-degree lift of both the head and the feet, and the heels should always be elevated. So basically what we're saying here is that trochanter pressure injuries and heel pressure injuries should never happen. If that happens, it means that our nurses do not know how to position the patient properly.
So we're here to demonstrate how to do the 30-degree tilt. This is a way of repositioning your patient so that you redistribute the pressure, take it away from the bony prominences like the hip here and the sacrum and the heels, and you put the pressure instead onto the fattier parts of the body, so you're spreading out the load of pressure. And we do this just by using pillows, so it's really cheap and a very effective way of repositioning the patients. We've got Edwin here as a volunteer, and he's lying in the recumbent position, and we'll then demonstrate where to put the pillows in. So Edwin, if you roll towards us, And we'll put in the top pillow first. So this pillow goes between the first and the second pillow under the head, and it goes in at an angle. So Dawn's just put it in at an angle so it's positioned away from the body, and it's just tucked into where the sacrum is there. And then we roll our patient back, thank you Edwin, back to lie straight in the bed. And Dawn is just sliding her hand underneath to check that the pressure's off the sacrum. So there's just a little bit of a gap there, so that you know that you've shifted the weight just slightly over onto the left buttock. Now we can't leave the legs unsupported, that would be uncomfortable, and it would also still got a lot of pressure under the heels. So pillow goes under this leg, if you lift the leg. Thank you. Georgina's put the pillow there so it's lying lengthways, supporting the whole leg, behind the knee, but just here, the heel is actually just lying free of the pillow and the mattress underneath. And then there's a third pillow to go in, and that goes in under this side. This pillow goes in again at a slight angle, right up towards the top of the leg, that's it. So it's lying at a slight angle this time, it's still supporting the knee, it's supporting the calf, and there are no peak pressures under the calf, and you've got again the heel just elevated away from the mattress. So in effect what you're doing, and hence the name 30-degree tilt, is tilting your patient from a flat position just ever so slightly to the side without bringing them right over onto the hip. So let's just check again. Sacrum clear. Do you want to just slide in your hand and make sure that underneath there, there's, yeah. Legs well supported, knees supported, heels just off the end of the mattress. Does it feel comfortable? It does. Thank you.
So as you see, turning the patient 30 degrees is not a difficult task to do. One of my suggestions to the nurse leaders is that a competency assessment of nurses should be done like we do the medication assessment, etc., because positioning our patients correctly is one of the huge deficits that we have in nursing all over the world. And we have all the guidelines from the MPUAP, APUAP, etc., who do suggest that the 30-degree tilt should be implemented. There are a couple of articles which say that the patients do not need to be turned. I would suggest to not take notice of those type of articles, making sure that we do that. The another question that comes up is, should we disturb the patient during the night? The answer to that is yes. Patients still need to be turned in the night. Maybe we don't need to turn them 2 hourly, maybe 3 or 4 hourly would be enough, but not turning the patient for a whole shift, remember, is a kind of a guarantee that that patient will get a pressure injury. Another thing that we might sometimes forget is not all patients in the bed only are at risk of getting a pressure injury. Patients who are chair fast or sitting on chairs for a long time are at even more risk than our patients who are bed-bound. So basically, if you have a patient who is chair-bound, first of all, making sure that the quality of the chair is good, that it is fitted properly for that patient. There are specialist physiotherapists that can assist you here, teaching the patient how to sit properly on the chair, making sure that we are using redistributing cushions underneath the chair, and also teaching these patients, if they can do it themselves, to shift their position about every 15 minutes. If they can't, we have to do it at least every hour. Remember the first video that we saw, how many pressure injury that patient got, probably because she was not given enough information, enough knowledge about how to manage herself in preventing pressure injuries. One of the things that helps us in nursing is these care bundles. Like, for example, we have the VAP bundle, the ventilated assisted pneumonia in the ICUs. But when it comes to pressure injuries, we have the Skin bundle. There are quite a few of them, but I think one of the mostly renowned and mostly implemented is the Skin.
So the first element of the skin pressure ulcer prevention bundle is surface, and that's when we'd like you to consider what equipment you might need to put in place for reducing or relieving pressure for your patient. But that element isn't just about looking at equipment, that's also about, is the equipment functioning? And also you need to make sure that the patient and their family are switched on to how that equipment works, because it may not be in the acute setting, it may actually be in the patient's own home. And obviously the functionality of the equipment is really important. So the second element of the skin bundle is skin, and this is an incredibly important element because you're looking at the state of the skin. Is the skin moist? Is it excoriated? Does the patient have any long-standing skin conditions? So it's all about skin inspection. Also, what we want you to do is manage any skin issues. So make sure there's a management strategy in place to deal with if there's moisture or excoriation or any form of skin disease that's existing. So the third element of the skin bundle is keep moving. And of course, everybody knows this is incredibly crucial in pressure ulcer prevention. And that's about assessing your patient's mobility issues, make sure a mobility assessment has been carried out. And then you are looking to make sure that you have put in place a repositioning schedule. Now, of course, that may be your patient needs frequently moving, or it may be that the patient only needs repositioning every 4 to 6 hours. That has to be clinical judgment at the time of your assessment. Again, this is really important that the patient and their family are involved in this, because often the patient can do much more moving than you actually think they can. So it's important that you have that discussion with them before you put any repositioning schedule in place. To prevent a pressure ulcer is reposition, reposition, reposition. The fourth element of the skin bundle is incontinence and moisture management. Now, not all patients are incontinent, and it may not be that they have incontinent moisture issues. It may actually be that they're sweating. If your patient suddenly develops a urine infection or a chest infection, you may find that their skin becomes much more sweaty than usual. This, of course, can play havoc with the stratum corneum, the top layer, your epidermis, and that's what you don't want to break down. Also, in this element, it's really important to think if the patient is in any pain, and you need to be talking to them about what strategies they've had in place before they come into your care. So the final element of the skin bundle is nutrition and hydration. This is really important. You want to be looking at your patient's nutrition status. They should have a MUST score carried out on assessment when they first come into your care, whether that's in the acute setting or whether that's in the residential care, nursing home, or in the community setting, the patient's own home. You need to be addressing any intake issues if they're not taking enough diet on board or they're not taking enough fluid. Hydration for the skin is incredibly important and is a high risk if you have dehydrated skin that the patient can develop skin breakdown much quicker. You need to also consider in this element of the bundle whether you need to refer on to a dietitian to give you more assistance with the patient's intake. That will be both oral and taking in fluids as well. And it may be they want to supplement the patient's diet.
The skin bundle has also evolved, and in the latest publications, we see that they have changed that to asking. They have included now an A at the beginning, which is the holistic assessment, obviously, and the G at the end, which is the important part of giving the education and the information to the patients and their carers, and also other healthcare professionals. One of the last questions for you: do donut-shaped cushions help relieve pressure, therefore helpful in pressure injury prevention?
Ah non. Non, non. J'avais des demandes de renseignements que j'ai jamais reçus, mais non, elle n'était pas inscrite. J'avais demandé sur le site, effectivement, des demandes d'information.
Okay, so I see that almost half of you have said that they do. Please be careful. These type of old contraptions like the donut cushion will actually put your patients more at risk, because basically what is happening, that donut will occlude the circulation at the center. The synthetic skin, cheap skins, the gloves filled with fluid, IV bags, these should not be used, because these actually cause more damage than not. We don't need to place the heel on a water-filled glove. We know that the heel needs to be elevated. One of the tools which is used a lot is the turning clock. It doesn't cost us anything at all. You just print this out, put it in the patient's room. So for example, if we go in the patient's room between 8 and 10 o'clock, the patient needs to be at the left lateral position. Another thing which is not directly and as part of the pressure injury prevention program is the implementation of the hourly rounding and the 6Ps. So this is something that will give us more control over the patients. Many people think that it will increase the workload. It actually decreases it, because we are keeping our patients safer and we are anticipating the need of our patients. When a pressure injury does happen, remember that we still use the acronym that we used in the previous session, which is the DIME, debridement, infection, inflammation, control, moisture imbalance, and edge of the wound. In a stage 1 or a deep tissue injury, there is no wound. We don't need to use any dressings at all. All we need to do is offload the patient. In a stage 2, what we need to do is, because it's a very superficial wound, we can use a non-adherent dressing. If the patient is susceptible for infection, we can use something which is a non-adherent dressing with antimicrobials as well. 3 or 4, it's depending on the depth of the wound. It's always important that the dead space is filled without causing too much pressure. So we gently pack the wound and don't leave any spaces. But again, depends on the DIME. Do we need to dislough? Is there infection, etc. In a non-stageable, it's again the discussion we had during the DIME part, where we have to decide if it is advisable or not to remove the necrotic tissue to enhance healing of the wound. So pressure injuries are chronic wounds, which needs to be treated as a chronic wound, making sure that we are using the DIME in an appropriate way. So that is basically all we have for you for today. If there are any questions, I'll be more than happy to respond.
Hi, Emilio, are you there?
I am here.
Yep, in the chat, I think Sister Vivian had an earlier question about the classifying the PI across the exact location.
When we are looking at the restaging, as we said, we do not reverse stage. If it's a stage 4, it will be a stage 4 until it is totally healed. If flap or a graft is used, then it becomes a surgical wound, and we document it differently. The extent of the location, what we have to document is the anatomical location. So if it's on the bridge of the nose or on the sacral area, then we do the assessment like we do for other wounds with the size, the depth, etc., etc. I don't know, Vivian, if that was your question.
Yes, but my question is, like, we do have the incident whereby stage 4 PI has been healed, but then it reoccur again. So in that circumstances, do we need to document stage 4 PI, or how shall we document then?
Reoccurrent stage 4 pressure injury, even if it is superficial. So when you are doing the incident report, we say that it was a stage 4, it was healed, and now is recurrent. So it is basically the same wound.
Okay.
Yep.
Thank you. Yep.
Any other questions or comments, please? So my suggestion to you guys is education of yourselves, education of the carers, of the patients, and of your colleagues. Education and awareness is what reduces the incidence of pressure injuries, making sure that we are positioning the patients properly, suggesting that the 30-degree turn becomes part of your annual competency assessment. How do we differentiate KTI and PI in daily? Well, a very good question. The KTI looks like usually like a deep tissue, or you have erosion of the skin, and this happens in a patient which are actively dying, even though you have elevated or turned the patient. So you can turn the patient, but the patient still get that. So through the condition of the patient and the history, you can determine if it is a KTI, a thrombolyphromatosis, or a pressure injury. I hope that answers your question. Does silver dressing recommend? Does include toxicity? So silver dressings are quite safe to use. Depends on the type of dressings that you use. You can check later on with Jonathan. We can offer you a non-adherent silver dressing, which will give you that non-adherence that you want, and the level of silver that is safe to use, but effective against the microorganisms. So remember the evidence-based practice. The dressing that you are using should have evidence-based behind it. Look at the effectiveness of the dressing, but also look at how safe it is to use. It is very, very difficult to get absorption of silver in the bloodstream. Cytotoxicity from silver is very, very uncommon. But again, use a dressing which you know it is safe. Again, Jonathan can help you choosing the correct dressings for your patients. You're more than welcome.
Hi, Mr. Emilio. Good evening.
Hi.
Yes, Regis here. Okay, just want to ask about the IAD progress to PI for stage 3 from the IAD patient developed to PI until it goes worsen up to stage 3. How are we going to document for this condition?
So initially it was an IAD, the patient was not positioned correctly, and because the patient is more prone, it has become a stage 3 now. So basically you've started documenting it as an IAD, but now it has become as a pressure injury, so you start documenting it as a pressure injury.
Okay, thank you.
Any other questions or comments? I think that is it, Jonathan. If there's nobody else who wants to comment or ask questions, I think we can wrap it up, yeah?
Yep, I think we're good. All right. Okay.
Thank you very much.
5:31. Thank you everyone for coming. Have a good evening.
Thank you. Thank you, everyone.
Thank you.
Thank you. Bye.
You. Bye.
Bye.